The global understanding of hantavirus transmission has undergone a profound shift, fundamentally altering how public health agencies approach the containment of this highly lethal pathogen. Historically, hantaviruses were classified strictly as zoonotic diseases, requiring direct or indirect contact with infected rodent hosts to spread to humans. However, epidemiological investigations into the Andes virus strain have established a critical exception to this rule, proving that person-to-person transmission can and does occur through respiratory aerosols. This discovery, validated by international health bodies, transforms a localized agricultural hazard into a complex public health challenge that demands rigorous surveillance and containment strategies. The implications are severe because hantaviruses cause two highly lethal clinical syndromes: hemorrhagic fever with renal syndrome, primarily seen in Europe and Asia, and hantavirus pulmonary syndrome, which is prevalent in the Americas. While typical hantaviruses require humans to inhale aerosolized particles from infected rodent urine, feces, or saliva, the specific ability of the Andes strain to pass directly from one human breath to another elevates the virus from an isolated environmental risk to a potential agent of community-level outbreaks. Viewers must recognize that while widespread pandemics remain unlikely due to the specific conditions required for transmission, the high fatality rate of hantavirus pulmonary syndrome, which often exceeds 35%, makes any shift towards sustained human-to-human transmission a matter of intense global concern. Understanding the mechanisms behind this respiratory spread is essential for interpreting official health directives, hospital protocols, and international travel advisories. This report examines how a pathogen traditionally confined to rural fields and abandoned buildings has demonstrated the capacity to bypass its rodent reservoir entirely, presenting an immediate challenge to clinicians, laboratory researchers, and epidemiologists worldwide, who are tasked with monitoring and neutralizing these emerging biological threats. The clinical and laboratory investigation into person-to-person transmission has forced public health agencies to re-evaluate their diagnostic and containment infrastructure. In regions where the Andes virus strain is endemic, particularly within parts of South America, medical centers and research laboratories have documented clusters of infections that cannot be explained by exposure to rodent populations alone. Epidemiologists tracing these chains of infection discovered that family members, healthcare workers, and individuals in close contact with primary patients were contracting the illness weeks after the initial exposure, matching the virus's known incubation period of 1 to 6 weeks. When laboratory technicians sequenced the viral genomes isolated from these clusters, they found nearly identical genetic profiles across multiple patients within the same chain, providing definitive molecular evidence of direct human-to-human transmission. This development places an immense burden on hospitals and clinical laboratories, which must rapidly differentiate hantavirus pulmonary syndrome from common respiratory illnesses during its early stages. Initial symptoms, including fever, muscle aches, and fatigue, mimic standard viral infections, but the rapid progression to severe respiratory distress requires immediate intensive care intervention. For healthcare facilities, the confirmation of aerosol transmission requires strict infection control protocols, including the isolation of suspected cases and the use of specialized personal protective equipment, such as respiratory protection, to safeguard medical staff. Public health agencies continue to monitor these developments closely, cross-referencing field data with laboratory findings to determine if other hantavirus strains could mutate to exploit similar respiratory pathways. Though current data suggests this trait remains uniquely identified with the Andes variant, mitigating the risks associated with hantavirus requires a dual approach that combines active environmental surveillance with strict public adherence to hygiene and prevention guidelines. For standard zoonotic hantaviruses, prevention focuses heavily on rodent control and the safe cleanup of infested areas. Public health agencies advise against sweeping or vacuuming rodent droppings, as these actions actively loft infectious viral particles into the air, creating the exact aerosolized state that leads to human infection. Instead, guidance dictates the use of disinfectants or bleach solutions to thoroughly wet contaminated surfaces before removal, alongside the utilization of appropriate respiratory protection. In the context of the Andes strain and its capacity for person-to-person spread, public health strategies expand to include rigorous contact tracing, quarantine protocols for exposed individuals, and enhanced surveillance at regional transit hubs if localized outbreaks are detected. Significant limits of knowledge remain, as scientists are still working to determine the precise viral load required for human-to-human transmission and whether asymptomatic individuals can shed the virus. As research continues in specialized high-containment laboratories, official guidance emphasizes calm, methodical adherence to sanitation protocols and immediate medical consultation if respiratory symptoms develop after potential exposure to rodents or known cases. For ongoing updates on global public health developments and epidemiological analysis, consider subscribing to this channel. The clinical, laboratory, and epidemiological investigations into the person-to-person transmission of the Andes hantavirus strain have forced international public health agencies to completely reevaluate their diagnostic, containment, and hospital infrastructure. Historically, when a patient presented with symptoms of hantavirus pulmonary syndrome, the immediate operational response by field epidemiologists was to locate an environmental source, such as an infested barn, a rural residence, or an agricultural workplace where wild rodent reservoirs, specifically sigmodontine rodents, had shed viral particles. However, detailed contact tracing during localized outbreaks in South America revealed anomalous clusters of infection where secondary and tertiary patients had absolutely no history of rural exposure or contact with rodent habitats. Instead, these individuals shared a common denominator: close, prolonged contact with an index patient during the early, highly infectious stages of the disease. Epidemiologists mapping these chains of infection noted that family members, caregivers, and individuals sharing enclosed spaces, such as domestic rooms or transport vehicles, contracted the illness within a time frame that precisely matched the known incubation period of the virus, which typically spans from 1 to 6 weeks. This pattern provided compelling epidemiological evidence that the virus was bypassing its traditional animal vector and propagating directly through human populations via respiratory droplets and fine particle aerosols generated during normal breathing, talking, or coughing. To confirm these field observations, reference laboratories conducted rigorous molecular sequencing of viral RNA extracted from patients within these identified clusters. The genetic sequencing revealed near-identical viral genomes across individuals within the same transmission chain, a molecular signature that definitively proved person-to-person transmission, as independent spillover events from wild rodent populations would exhibit greater genetic diversity. This confirmation has placed a critical burden on hospitals, intensive care units, and clinical laboratories worldwide. The early clinical presentation of hantavirus pulmonary syndrome is notoriously nonspecific, characterized by systemic prodromal symptoms, such as high fever, severe myalgia centered in the large muscle groups, headache, and profound fatigue, which closely mimic common seasonal influenza, dengue fever, or other endemic viral infections. Within days, however, the disease progresses rapidly and unpredictably into a catastrophic cardiopulmonary phase, marked by sudden non-cardiogenic pulmonary edema, severe respiratory failure, and cardiogenic shock due to widespread capillary leakage, because there are currently no widely approved specific antiviral therapies proven to cure hantavirus pulmonary syndrome. Clinical management relies entirely on early recognition and aggressive supportive care within intensive care units, often requiring mechanical ventilation or extracorporeal membrane oxygenation to sustain life while the patient's immune system combats the infection. For healthcare facilities, the validation of human-to-human aerosol transmission requires the immediate implementation of stringent infection control protocols. Hospitals must rapidly isolate suspected or confirmed cases in negative pressure airborne infection isolation rooms to prevent the migration of respiratory aerosols into common hospital corridors. Healthcare workers attending to these patients must utilize high-level personal protective equipment, including fitted N95 or powered air-purifying respirators, fluid-resistant gowns, and eye protection, shifting away from standard droplet precautions to full airborne containment strategies. Furthermore, laboratory personnel handling patient blood and tissue samples must adhere to strict biosafety Level 3 operational protocols to mitigate the risk of laboratory-acquired infections through accidental aerosolization during routine processing, centrifugation, or diagnostic testing. Public health agencies and international reference laboratories maintain continuous surveillance over these developments, analyzing viral samples from around the globe to monitor for any genetic mutations in other hantavirus strains, such as the Sin nombre virus in North America or the Pumala and Dobrava viruses in Europe and Asia that could potentially allow them to acquire similar human-to-human transmission capabilities. Though current scientific consensus indicates this aerosol pathway remains uniquely verified within the Andes virus lineage, mitigating the public health risks associated with hantavirus requires a dual-pronged strategy that seamlessly combines active environmental surveillance with strict adherence to evidence-based personal prevention guidelines. For the vast majority of hantavirus strains globally, which remain strictly zoonotic, prevention is fundamentally rooted in rodent control, exclusion, and the safe decontamination of infested spaces. Public health agencies issue precise operational directives for cleaning structures such as cabins, barns, and storage sheds that have been closed for extended periods. A critical takeaway for the public is the absolute prohibition of dry sweeping or vacuuming areas contaminated with rodent droppings, nests, or urine. These actions physically loft dried viral particles into the air, creating the exact infectious aerosols that lead to deep lung inhalation and subsequent infection. Instead, standard protocol dictates that individuals must thoroughly saturate the affected area with a commercial disinfectant or a 10% bleach solution for at least 5 minutes before cleaning. This step effectively inactivates the lipid envelope of the virus, rendering it non-infectious. The material must then be wiped up using paper towels or mops while wearing rubber gloves, and ideally, a well-fitted respirator to completely eliminate inhalation risks in regions where the Andes virus strain is active. Public health measures must dynamically expand beyond environmental sanitation to encompass rigorous community-level containment. Because this specific lineage possesses the verified capacity for person-to-person aerosol transmission, containment strategies mirror those used for other severe respiratory pathogens. This includes the rapid implementation of contact tracing protocols, the monitoring of close contacts for early prodromal symptoms like fever and muscle aches, and the enforcement of voluntary or mandatory isolation periods for individuals known to have experienced high-risk exposure. On a broader scale, public health surveillance involves the continuous trapping and testing of wild rodent populations by environmental biologists to map the geographic prevalence of the virus and provide early warning systems to nearby communities. Despite these robust protocols, substantial limits of knowledge persist within the scientific community. Researchers are still working to quantify the precise viral load required to initiate human-to-human transmission, the exact duration of viral shedding during a patient's clinical course, and whether subclinical or asymptomatic infections occur and play a role in spreading the pathogen. Barring these unknowns presents a complex ethical challenge for global public health authorities and the media alike. Reporting on highly lethal pathogens requires an uncompromising commitment to transparent, fact-based communication that informs the public without inciting unnecessary panic or stigmatizing specific regions and communities where outbreaks occur. Public health agencies must balance the ethical duty to warn citizens of potential risks with the responsibility to avoid economic disruption or social isolation of affected populations. This necessitates clear, non-sensationalized messaging that emphasizes known transmission mechanisms, available medical interventions, and practical preventative measures. As high-containment laboratories continue their critical work to develop effective vaccines and targeted antiviral therapies, international collaboration and open data sharing remain the cornerstone of global health security. Maintaining an informed, calm, and methodical approach to prevention and surveillance is our most effective tool